So starting off the prenatal care, what are some first trimester prenatal labs and screenings that we typically get? And I should say this varies by institution to institution. Typically, people get a CBC, blood type, red blood cell antibody screening, urine dipstick for protein, urine culture, HIV, Hep B, Hep C, and syphilis are usually universally gotten. Also, there's an ultrasound that people usually get for gestational age, and then their parents are usually offered genetic testing as well. Other things to consider are STI testing can be got if people are at risk for STIs such as chlamydia and gonorrhea. This is also always gotten for people who are less than the age of 25. So what are some other second trimester prenatal labs and screenings? Usually people get these in between like the 24 to 28 week gestation range. So you usually get another CBC just to see, just as screening, and then also you usually get an oral glucose test, which we'll get into later, as well as a fetal anatomy scan. And third trimester prenatal labs and screenings. This is when you typically get your Group B strep, usually 36 to 37 weeks. You also get syphilis testing again. If you're Rh negative and you've known Rh negative, you screen for Rh antibody and administer RhoGAM as needed as you're preparing for delivery. And then if risk factors for STIs, like we mentioned, screen for chlamydia and gonorrhea. And when can you perform chorionic villus sampling? I see 10 to 13 weeks in the chat. And then there's a risk of miscarriage whenever you're doing any of these invasive testing, as well as limb defects. And when can you perform amniocentesis? So that's typically 15 to 20 weeks. There's also risk of miscarriage as well as premature rupture of membranes and infection. And what are some typical vaccinations that we offer in pregnancies? So we typically offer Tdap at 27 to 36 weeks, flu for people who are immune to rubella or varicella. They should be vaccinated postpartum and not during pregnancy. And which has a higher risk of miscarriage, CVS or amniocentesis? And I see CVS in the chat. All right, so what is a normal fetal heart rate? Typically that's 110 to 160 beats per minute. Are accelerations normal? Yeah, they're common with fetal movement. So what's this slide showing? Yeah, this is showing an early deceleration. So the definition is it occurs synchronously with a contraction, and it's greater than 30 seconds from the onset to the nadir, which is the lowest point. And what's the cause? Uterine contractions causing head compression, which stimulates a vagal response and decreases in heart rate. And typically it's a benign thing that you don't have to worry about if you see these early decelerations. Now, what about this? Now, this is a late deceleration. And that's defined as a decrease in heart rate that begins after contraction onset and then returns to baseline. Usually it's 30 seconds from onset to nadir. And the cause? Uteroplacental insufficiency, and it's caused by transient fetal hypoxemia from contractions compressing blood vessels. And next steps, if you see this, you're going to want to consider intrauterine resuscitation, reposition the mother from supine to lateral decubitus, start IV fluids, and discontinue uterotonic agents. Now, what's this tracing showing? So this is variable decelerations, and the onset to the nadir is usually abrupt, less than 30 seconds, and lasts greater than 15 seconds, but less than 2 minutes. And what's the cause of recurrent variable decelerations? Usually umbilical cord / prolapse, and if you see this, you're going to want to treat it similarly to late deceleration, where you want to consider intrauterine resuscitation, repositioning the mother from supine to lateral decubitus, start IV fluids, and discontinue uterotonic agents. And there's a mnemonic for this, VL-CHOP. And what does this stand for? So this is an easy way to remember like the pathology of fetal heart rate tracing. So variable, which the V stands for, corresponds with cord compression. Early decelerations correspond with head compression. Accelerations are okay, and late is associated with like placental insufficiency. So what causes moderate variability? So moderate variability is typically normal. So there's no real cause, and it's considered between 6 and 25 beats per minute on the fetal heart rate tracing. And what if you see absent variability on the FHT? So this is caused by severe acidemia, and given the definition, you just don't see any amplitude. And what if you see marked variability? How do you define that? So that's defined as greater than 25 beats per minute, and that is caused by fetal hypoxia and cord compression. And the really bad one, what if you see sinusoidal variability? So this is also caused by severe anemia and hypoxia, and the definition is the fetal heart rate resembles a sinus wave. So category 1 fetal heart rate tracing is considered when you have the heart rate between 110 and 160 beats per minute, moderate variability, and no late or variable decelerations. And this is good. You want all people to have category 1 fetal heart rate tracings. Category 3 fetal heart rate tracings, on the other hand, is when you see things that are concerning, like an absent baseline fetal heart rate variability and one or more of the following. So like recurrent late or variable decelerations, bradycardia, or a sinusoidal pattern. And category 2 is defined as neither category 1 or category 3. And what does APGAR stand for? So going through it, appearance, pulse, grimace, activity, respiration. And so this is just a way that we can assess how babies are doing once they're first born. And greater than 7 is reassuring. Here's a table showing it, showing how you get 0 points through for 2 points for everything. And like I said, greater than 7 is reassuring. So we have a newborn with hypotonia, flat facial profile, upslanting palpebral fissures, epicanthial folds, ASD, single palmar crease, and a gap between the first and second toes. What is your diagnosis? So we'd be concerned for Down syndrome. And what's the biggest risk factor for Down syndrome? Advanced maternal age. And what GI organ conditions are associated with Down syndrome? There's a couple. So there's Hirschsprung's disease, that's the one associated with like the squirt sign on exam, and then there's also duodenal atresia, that's the double bubble on imaging. And then you also have annular pancreas. So now we have a newborn with low set ears, clenched fists with overlapping fingers and a rocker bottom feet, and they have a VSD. What are we worried about here? Here we would be worried about Edwards syndrome. And what about a newborn with cleft lip and palate, rocker bottom feet, polydactyly, and a VSD? They also are missing an area of skin on the scalp. Here we'd be concerned for PATU, or trisomy 13. So there are different serum markers that can be indicating whether someone might be at risk for having these syndromes. So the big one associated with trisomy 21 is the beta HCG, as you can see here. And then additionally, the inhibin A is high in trisomy 21, and then you can see the others for 18 and 13 as well. So now we have a 15-year-old girl with short stature, coarctation of the aorta, webbed neck, short fourth fingers bilaterally, widely spaced nipples, and they come in for concerns with lack of menses. Here we'd be worried about Turner syndrome. And what's the pathophys, or what causes Turner syndrome? So this would be you're missing an X chromosome, so it's 45XO phenotype. And what's the pathophys of the amenorrhea? You get streak ovaries, which cause primary ovarian insufficiency. You get low estrogen, low androgens. And then that also causes high FSH and LH. So we have a 27-year-old G1P1 who presents to the ED with severe lower abdominal pain and light vaginal spotting. Last menstrual period was 5 weeks ago. What would our next steps be in the ED? You're always going to want to get a pregnancy test, and then additionally here you'd also want to get an ultrasound. So the pregnancy test is positive. The ultrasound shows an empty uterus with an adnexal mass. What would you be concerned for? You would be concerned for an ectopic pregnancy. And so you'd want to, this is a surgical emergency, so you'd want to do an X-lap if they're unstable, but if they are stable, then you'd want to do methotrexate. So I guess not a surgical emergency. So now you have a 32-year-old G2P1 woman at 30 weeks gestation who presents with a blood pressure of 145/95. They also had an elevated blood pressure at a different visit. They have no complaints and no history of hypertension. They have a UA that shows no signs of proteinuria, and their CBC creatinine is normal. What is the likely diagnosis? So this would be gestational hypertension, and that's defined as blood pressure greater than 140/90 on 2 different occasions after 20 weeks. And how do you treat gestational hypertension? Usually you don't treat unless the blood pressure is greater than 160/110. Labetalol is typically used first line, but it can cause bradycardia. You can use hydralazine if bradycardia is present. You want to avoid ACEs and ARBs in pregnancy as they are teratogenic. If they remain poorly controlled, even despite all these, you're going to want to hospitalize until you can deliver at greater than 34 weeks. So now you have a 37-year-old G1P0 woman at 34 weeks gestation who presents with persistent headaches, blurry vision, and swelling in her hands and face. Her blood pressure is 166/100. Labs show proteinuria and elevated LFTs. What is your diagnosis? So here you'd be worried about preeclampsia with severe features, and this would be defined as gestational hypertension plus end organ damage. For example, thrombocytopenia, creatinine greater than 1.1, elevated LFTs, or headaches. And what are some risk factors for preeclampsia? There's a lot. So nulliparity, twins, chronic hypertension, obesity, diabetes, lupus, and advanced maternal age. And how do we treat preeclampsia? You're going to want to give IV Magsulf for seizure prophylaxis, antihypertensives, and considered delivery as the definitive treatment. What are some complications of preeclampsia? You can get pulmonary edema, heart failure, liver failure, DIC, and stroke. In contrast, a patient is at 20 weeks, has gestational hypertension and 2+ protein in the urine with no symptoms. This would be preeclampsia without severe features. And for this, you're going to want to treat with low-dose aspirin, which is typically initiated between 12 to 28 weeks until delivery at term. A 25-year-old woman, G2P1 at 36 weeks gestation with history of preeclampsia presents to the ED after experiencing a tonic-clonic seizure. Blood pressure is 170/110. What are we concerned for here? Eclampsia, and this can occur pre or post delivery. And how do we treat eclampsia? Magsulf and delivery. Of note, Magsulf is contraindicated in myasthenia gravis. So they get their Magsulf, they develop decreased deep tendon reflexes, respiratory rate of 8, and they suddenly look drowsy. Here we'd be concerned for magnesium toxicity, and the antidote you would give them is calcium gluconate. All right, so now we have a 30-year-old G3P2 woman at 35 weeks gestation who presents with severe right upper quadrant pain, nausea, and worsening fatigue. Laboratory studies reveal hemolysis, elevated LFTs, and a platelets count of 80,000. Blood pressure is 130/80. Here we're concerned for HELLP syndrome. And why do you get the right upper quadrant pain? You get stretching of Glissen's capsule from liver swelling. And you treat this by delivering baby. So now you have a G4P2 woman at 32 weeks gestation with sudden onset abdominal pain, heavy vaginal bleeding. Her uterus is firm, rigid, and tender. No recent trauma, but has history of cocaine use during this pregnancy. Currently hemodynamically stable. What are you concerned for? Here you'd be concerned for abruptio placentae, where the placental starts bleeding. And what would the next steps be? You're going to want to put them on fetal heart rate monitoring. You're going to give them IV fluids and then consider blood transfusion if their hemoglobin's low. So if she begins to develop profound hypotension, what's the next step? C-section. So now you have a 20-year-old G2P1 woman at 30 weeks gestation who presents with painless red vaginal bleeding. On physical exam, her uterus is soft, non-tender, with normal fetal heart tones. What are we worried for here? So here we're worried for placental previa. And the next steps would be just to do an ultrasound, make sure baby's stable, and observe. Most placenta previas resolve spontaneously, and if it persists, you're going to want to keep getting ultrasounds, making sure that it goes away, and a C-section if it does not go away by 36 weeks. And we typically counsel patients to avoid sex, strenuous activity, and prolonged standing. So in contrast, you have a 28-year-old G1P0 who presents with painless vaginal bleeding immediately after rupture of membranes. She hasn't had any prenatal care. On physical exam, her uterus is soft and non-tender. Her vital signs are normal, but her fetal heart rate tracing show a sinusoidal pattern. Here you'd be concerned for vasa previa. And so this is caused by you have fetal blood vessels that pass or near over the cervix with no or decreased Wharton's jelly, so nothing protecting them. And so this is an emergency C-section is how you're going to want to treat it, because this is baby's blood you're losing, and baby has a lot less blood than mom, so you're going to want to do an emergency delivery. So now we have a 23-year-old woman at 39 weeks gestation who undergoes a C-section. During delivery, you try and remove the placenta, but it's abnormally adherent to the uterine wall. Attempts at manual separation results in significant hemorrhage. What are we concerned for here? Accreta. So placenta accreta. And what is this caused by? This is caused by the placenta being attached to the myometrium, not the endometrium. And risk factors here would be history of prior uterine surgery, such as a C-section ablation, placenta previa, and Asherman syndrome. Anything that causes scarring in the uterus, and then would potentially cause like abnormal attachment of the placenta to the myometrium rather than the endometrium. And how do you treat it? C-section with the placenta in situ due to high risk of maternal hemorrhage from bleeding. So instead, we have a woman at 40 weeks gestation, history of prior C-section with sudden onset severe abdominal pain during active labor. On exam, uterus is tender and has irregular contour. Contractions have stopped. There's light vaginal bleeding, but she's tachycardic and hypotensive. So this would be concerning for uterine rupture. And what are some risk factors of uterine rupture? You can get it can be caused by prior C-section, myomectomy, post-term pregnancy, and macrosomia. And you would treat this by airway stabilization. You don't want to give any uterotonic agents and just do an emergency C-section. So now you have a 26-year-old G1P0 woman at 10 weeks gestation who presents with a history of heavy vaginal bleeding, cramping earlier in the day. Exam shows her uterus is small, non-tender, and the cervical os is closed, and there's no active bleeding. Ultrasound reveals an empty uterine cavity with no products of conception. This would be a complete spontaneous abortion, and that's defined as a closed cervical os with no products of conception. And how do we manage this? Mostly supportive care. And common etiologies of complete spontaneous abortion would be chromosomal abnormalities, reproductive organ abnormalities, and then systemic diseases like hypercoagulability. How does an inevitable abortion present? So this would present with bleeding, a dilated cervical os instead, and products of conception are still visualized. You can still have cardiac activity as well. What about how does a missed abortion present? So you'd have no bleeding, no products of conception, a closed cervical os, and no cardiac activity. And what about an incomplete abortion? So you'd have bleeding, no cardiac activity, products of conception partially expelled within the cervical canal/uterus, and an open cervical os. And what about a threatened abortion? So you'd have bleeding, cervical os, heartbeat if they're old enough. It can still be viable, actually. And you're going to want to get a weekly ultrasound and HCGs until bleeding resolves. And how do you treat an inevitable, incomplete, or missed abortion? You're going to want to do medical or surgical evacuation. You're going to want to also give RhoGAM for RHD negative patients. So what about a 25-year-old G2P1 woman who presents with fever, abdominal pain, and heavy vaginal bleeding 3 days after an incomplete abortion? Their physical exam reveals uterine tenderness, foul-smelling discharge, and labs show leukocytosis. What are we worried about here? Septic abortion. And treatment for this? Broad-spectrum antibiotics, RhoGAM for Rh negative patients. And how do you define pregnancy loss after 20 weeks? This is intrauterine fetal demise. And for this, if it's before 24 weeks, you're going to want to do D&C. And then after 24 weeks, you're going to want to induce labor. So now we have a 30-year-old G3P2 woman who presents with profuse vaginal bleeding immediately postpartum after a spontaneous vaginal delivery at term. On exam, the uterus is enlarged, soft, and boggy. Here you'd be concerned for uterine atony. And what's the pathophys of atony? It's failure of the myometrium to contract down and compress spiral arteries. And some risk factors for atony: macrosomia, polyhydramnios, multiple gestations, multiparity, post-term chorioamnionitis, and fibroids. The biggest thing here is if you see boggy uterus, that gives it away. It's always going to be uterine atony. And normally the uterus should be at the umbilicus and firm, but if you see like this bogginess or see like a uterus above the umbilicus, that's when you get concerned for this. And what are treatments for atony? You're going to want to do a uterine massage and oxytocin. You can also do carboprost, which is contraindicated in asthma, or this medication, which is contraindicated in with a history of hypertension, which is second line. You're also going to want to give TXA and a balloon. You're going to want to do balloon tamponade if the atony persists. All right, so we have a 28-year-old G1P1 who develops sudden severe lower abdominal pain and significant postpartum hemorrhage following delivery of the placenta. Exam shows a firm, well-rounded mass protruding through the cervix into the vagina with inability to palpate the uterine fundus. Okay, this is actually where I want to start, so I'm just going to start here. So what are some other causes of immediate bleeding postpartum? So other causes could be birth, GU trauma, retained placenta, and coagulopathy. So what are you concerned for if you have a patient with fever, uterine tenderness, foul-smelling lochia 3 days postpartum following arrested labor and a C-section? Here you're concerned for postpartum endometriitis. And what are common bugs that cause this? It's usually polymicrobial because it's from retention of the loclia. There's listed some common ones there, and you're going to want to use broad spectrum antibiotics for this. So typically first line's Clinda and Gent. Now, when do you screen for gestational diabetes, and how do you screen for gestational diabetes? You're going to want to screen with a glucose challenge test at 24 to 48 weeks gestation, and there are different ways to screen for this. But you can have the two-step, which is a 50-gram, 1-hour test, which is positive if it's greater than 140. And the diagnostic test, if this is positive, you're going to want to do is a 100-gram test, 30-hour glucose tolerance test. There's also one step where you give someone 75 grams and then you measure them at 1 hour and 2 hours, and this one's diagnostic. And what complications are increased if you have gestational diabetes? Preeclampsia, eclampsia help. Additionally, macrosomnia, cardiovascular defects, neuroturb defects, dystocia, caudal regression syndrome. And here's like the ideal ranges you're going to want people to remain in, and you're going to want to treat it with diet and exercise. If it's uncontrolled still, you're going to want to start insulin. Metformin can also be used in the second and third trimesters as well, but there's concern that it does cross the placenta, so there's concern that there might be some other effects. So we typically try insulin first, and then additionally postpartum, you're going to want to screen with a 2-hour glucose tolerance test. So now you have a 27-year-old at 18 weeks gestation, presents for routine prenatal care. Ultrasound shows fetal weight below the 10th percentile. Both the head circumference and the abdominal circumference are proportionally reduced. What's your diagnosis? This would be a systemic growth restriction, and this typically presents before 20 weeks. And what causes this? Intrinsic factors like genetic abnormalities and infections. So what if you have a 32-year-old G2P1 at 30 weeks gestation and their fundal height is small, ultrasound reveals estimated fetal weight below the 10th percentile, abdominal circumference is 10th percentile, while the head circumference is 35th percentile. This would be asymmetric fetal growth restriction. And what's the cause of this? Reduced fetal nutrients from placental insufficiency can be due to hypertension, diabetes, smoking also can cause it, or maternal malnutrition. So now you have a 30-year-old woman with history of recurrent painless second trimester pregnancy losses. They have an ultrasound that reveals cervical dilation at 18 weeks with a cervical length of 20 or 12 millimeters. What would be your diagnosis here? This would be cervical insufficiency. And how do you diagnose it? Multiple ways. So if someone has history of 2 or more recurrent pregnancy losses, especially in the second trimester, you can diagnose it then. Additionally, with a length of less than 25 millimeters in the second trimester, and additionally just with a dilated cervix before 28 weeks. And what are some risk factors for this? Previous OB/GYN trauma, or just like a genetically short cervix. And how do you manage this? You can do a cerclage, which is where you kind of stitch the cervix shut. You can also give intravaginal progesterone. So now you have a 27-year-old G2P1 at 33 weeks gestation who presents with a gush of clear fluid from the vagina, intermittent cramping. Their exam shows pooling of amniotic fluid in the vaginal vault with positive ferritin and nitrazine testing. Here you are concerned for preterm, pre-labor rupture of membranes. And what's the initial management of this? You're going to want to put them on a fetal heart rate monitor. You're going to want to start GBS prophylaxis if their status is unknown. If they're 34 to 36 weeks, you want to give antibiotics plus or minus steroids and then try delivery. If they're less than 34 weeks and unstable, you're going to do the same thing. And then also initiate Magsulf if less than 32 weeks with delivery. So now you have a 29-year-old G2P1 woman at 37 weeks gestation presents with nausea, vomiting, epigastric pain, jaundice over the past week. Labs show elevated liver enzymes, hypoglycemia, hyperbilirubinemia, and coagulopathy. What's your diagnosis? Acute fatty liver pregnancy. So what if instead you have a 31-year-old G3P2 woman at 34 weeks gestation who presents with intense pruritus predominantly over the palms and soles without associated rash? Labs shown elevated total bile acids, mild transaminase elevations, and mild elevated bilirubin. Here instead you'd be concerned for intrahepatic cholestasis of pregnancy, and the treatment would be UDS. What about a 25-year-old G1P0 woman at 22 weeks gestation who presents with right upper quadrant pain, nausea, fever? Physical exam reveals localized tenderness to the right upper quadrant, and they have a history of a cholecystectomy. Appendicitis. Now you have a 23-year-old G1P0 woman at 9 weeks gestation presents with persistent nausea, vomiting, inability to tolerate oral intake, resulting in 7 weeks weight loss from her pre-pregnancy baseline. She is hypotensive. Physical exam reveals dry mucosal membranes and tachycardia. Lab studies show ketonuria and hypokalemia. What's your diagnosis? This would be hyperemesis gravidum. And how do you treat that? IV fluids, thiamine, because there's a risk for Wernicke's encephalopathy, and electrolyte repletion. And management would be giving them doxylamine and pyridoxine. You're going to want to counsel them on eating when hungry and avoid an empty stomach. And risk factors for this would be mole and multifetal gestation. So you have a patient with no prenatal care. They're HIV positive. What do you do next? Measure their viral load. If it's greater than 1,000 or unknown, you're going to want to give them treatment. If it's less than 1,000, there's typically low risk for HIV transmission. You're going to want to do vaginal delivery for the infant and administer treatment at 4 weeks of age. So now we have a 32-year-old G3P2 woman who presents 6 months postpartum with fatigue, failure to lactate, secondary amenorrhea, following significant postpartum hemorrhage requiring transfusion. Labs show low serum cortisol, TSH, and prolactin levels. What's this consistent with? And this would be consistent with Sheehan syndrome. And how do you diagnose this? You do hormone testing and a head MRI. And how do you treat this? Hormone replacement. Now let's say we have a 35-year-old woman who develops sudden onset dyspnea, tachypnea, hypotension, and hypoxia during labor. Exam shows cyanosis. She's bleeding from all her IV sites and has significant uterine hemorrhage. What's the diagnosis? So this would be an amniotic fluid embolism. And how do you treat this? You're going to want to assess ABCs. You're going to want to do an emergency delivery. You're going to want to give blood products and treat the DIC. And this is often fatal. Which trimester is the fetus most susceptible to teratogens? Typically in the first trimester, especially before 8 weeks from conception, because that's when the embryonic period organogenesis occurs. You can get structural defects. What are some examples of teratogens? So here I've listed some high-yield ones. ACEs, ARBs, aminoglycosides can cause deafness. Tetracyclines can cause teeth problems. Fluoroquinolones can cause cartilage damage. And TMP, SMX can cause neural tube defects. And what are some risk factors for this? Now, fetal hydrotonin syndrome is associated with which anti-epileptic? So this would be phenytoin. Okay, and when is rubella infection the most common in pregnancy? This would be the first trimester. And how does congenital rubella syndrome present? So you get sensorineural deafness, cataracts, blueberry muffin rash, and microcephaly. And there's a mnemonic for this, which is I, heart, ruby, earrings. I for eye, which is cataracts. Heart for PDA. Ruby for rubella, and earrings for deafness. And how do you prevent rubella? Vaccination before pregnancy. It's not given during. And you also screen for rubella antibodies at the first prenatal. So now you have a neonate who presents with chorioretinitis, diffuse intracranial calcifications, and hydrocephalus on MRI. What's the diagnosis here? So this would be toxoplasmosis. And how do you treat the neonate? You're going to want to give them the following combination. And how do you prevent toxo during pregnancy? You're going to want to avoid raw meat, shellfish, cats, and wash your fruits and veggies. And how would you treat mom if they were known to have toxoplasmosis? So you give them spearmycin to prevent fetal transmission. Most maternal infections are asymptomatic, however, but they can present with lymphadenopathy and B symptoms. So now we have a neonate with hypertrophic scars, cataracts, limb hypoplasia, microcephaly, and chorioretinitis. So that's VZV. And how do you treat VZV? Acyclovir. So in a pregnant woman who's diagnosed with VZV, do we give the vaccine? No, because it's a live vaccine. So how does congenital CMV syndrome present? So this, more importantly, has no cataracts. Rubella is the only one that has cataracts. This one, you have the sensorineural deafness, blueberry muffin rash, microcephaly, and periventricular calcifications. So neonate presents with vesicular skin lesions, seizures, lethargy, and jaundice. This is HSV, and how do we treat this? You give acyclovir or valacyclovir. How is genital HSV transmitted at birth? Via genital tract lesions. It's not transplacental. And what to do if your mother has known HSV history? You're going to want to do acyclovir beginning at 36 weeks, continue until labor. Additionally, C-section is recommended if there's active genital lesions or if there's if the mom has prodromal symptoms such as vulvar burning or pain. How does primary and secondary syphilis present? So primary is that painless chancre, and secondary you have a mobiliform rash, the condyloma lata, and patchy alopecia. And how do you screen for syphilis? At the first trimester, you typically, everyone does an RPR or VRDL, or you can also do the FTA-ABS. And how do you treat this? Only penicillin. So even if they have an allergy, you're going to want them to undergo desensitization. And what's a complication of the treatment of syphilis? It's the Jarisch-Herxenheimer reaction. I think I said that right. Feel free to correct me if I didn't. And so you get B symptoms, tachycardia, tachypnea, and hypotension. So let's say a neonate presents with jaundice, hepatosplenomegaly, rash, and nasal discharge, aka snuffles. They also have a mobiliform rash on their hands and soles. What would you be thinking here? So this would be early syphilis. And how do you treat this? Penicillin, like we said before, 10 days of it specifically. And how would late congenital syphilis present? We typically don't see this nowadays, but you can get the Hutchinson's teeth, the saddle nose deformity, frontal bossing, keratitis, interstitial keratitis, and sensorineural hearing loss. So let's say a first trimester chlamydia NAT comes back positive. What's the treatment? So you're going to want to do 1 dose of azithromycin and attest a cure 2 weeks later. What if a gonorrhea NAT came back positive? So that would be ceftriaxone and test a cure 2 weeks later. So now we have a 23-year-old G1P0 woman at 10 weeks who presents with nausea, vomiting, vaginal spotting. Their beta HCG is greater than 100,000. What's the next step? Ultrasound. And the ultrasound shows heterogeneously echogenic intrauterine mass with a snowstorm appearance and no identifiable fetal structures. What would this diagnosis be? So we'd be concerned for a mole. And what would next steps be? We want to do a suction DNC. So the ultrasound also shows the bilateral cysts. What are these caused and called? What are these caused by and what are they called? So they're called ovarian theca lutein cysts, and they're caused by ovarian stimulation by HCG. So what's the difference between a complete and partial mole, and is P57 positive in which one? So complete, you have the 46XX, where you get fertilization of an empty egg by a sperm, and that's P57 negative. A partial, you have the 69XXY, so you get fertilization of the egg by 2 sperm, and that's P57 positive. And what do you do after DNC for treatment? So you follow the HCG until it's normalized. It can take a long time, 6 months, and if it does not normalize when you follow it, then you're concerned for neoplasia. And you're going to want to also offer contraception, as a new pregnancy will raise HCG, which might make it difficult to follow the HCG levels. So the HCG levels do not plateau. Ultrasound shows a poorly defined mass in the uterus with invasion to the myometrium, and the patient has bleeding vaginally. What are you concerned for? So this would be an invasive mole. How would you treat an invasive mole? Methotrexate or actinomycin D. You can also do a hyst. So the HCG does not plateau, and they still have vaginal bleeding. They now have cough with hemoptysis, and they have symptoms of hyperthyroidism. What are we concerned for? So they might have a choriocarcinoma. So the treatment is the same as an invasive mole, but one of the main differences is that it commonly metastasizes to the lungs. So what's the definition of dichorionic diamniotic twins and the timing of when they divide? So you have separate chorionic sacs and separate amniotic sacs, and typically they divide 3 days after conception. What about a monochorionic diamniotic definition and timing? So this, you'd have a single chorionic sac, but a separate amniotic sac, and they typically divide 4 to 7 days after conception. What about monochorionic monoamniotic definition and timing for those types of twins? So typically a single chorionic and amniotic sac, and they typically divide 8 to 11 days after conception. Here is a Wikipedia image just kind of showing the differences. So what's the pathophys of twin-to-twin transfusion syndrome? So you have the imbalance of blood flow of fetuses sharing one placenta, either through AV anastomoses in the placenta or vascular connections between twins. And what are complications for the recipient of the recipient twin in the twin-to-twin transfusion syndrome? So you get polycythemia, hypervolemia, and polyhydramnios. What about the donor twin? So the donor twin, you would get anemia, hypovolemia, dehydration, oligohydramnios, and growth restriction. So how do you define labor? So you'd have uterine contractions and cervical changes. And how do you define Braxton-Hicks contractions? So these are irregular contractions without cervical changes. They're typically less than 2 times an hour. They don't last longer than a minute. They do not become stronger or more frequent over time. So let's talk about the stages of labor. So what's the definition of the first stage? Phase, I should say. So this is the onset of uterine contractions to 6 centimeters cervical dilation. What about the active phase? So you have rapid cervical dilation from 6 centimeters to complete dilation of 10 centimeters. And what about the second phase? So this would be from complete dilation to deliver the baby, and then the third phase is the delivery of the baby to the delivery of the placenta. Here's a table kind of showing the differences. So you can see that the latent phase may last up to 20 hours in nulliparous and 14 hours in people who are multiparous. And yeah. Oh, and one other important thing is the third stage should occur within 30 minutes. So what must be done to induce labor? You're going to want a favorable cervix. So you can use misoprostol or prostaglandin E2 gels, or you can also do mechanical dilation. You can also use IV oxytocin and amniotomy if there's no rupture of membranes. And what's the risk of oxytocin use? So this can cause tachysystole. It can also cause hypoxemia and acidemia. Additionally, it can cause hyponatremia since it's structurally similar to ADH. It can also cause hypotension and fatigue because this relaxes smooth muscle. So if this happens, you want to reduce or stop the oxytocin dose and administer tocolytics like terbutaline. So what are some abnormal labor patterns? So failure of the cervix to dilate to 6 centimeters after more than 14 hours in multigravidas. So this would be a protracted latent phase. And what about dilation is greater than 6 centimeters, but progressing at less than 1 centimeter an hour? So this would be protracted active phase. And what about if you have, or how do you define arrested active phase? So this would be no cervical change for greater than 4 hours with adequate contractions, or 6 hours with inadequate contractions. So now we have a G2P1 patient at 38 weeks pregnant. Ultrasound shows breech. What do we want to do next? We want to consider an external cephalic version, and this is performed typically after 37 weeks, and if this fails, consider C-section. If less than 37 weeks, we don't have to necessarily intervene because most fetuses spontaneously convert. And what's the ideal fetal position? Occiput anterior. What are some risk factors for shoulder dystocia? So this would be macrosomia, post-term pregnancy, maternal diabetes, or obesity. And how does this present? Presents with the turtle sign, which is inability to deliver either shoulder with gentle downward traction. Those are two different things. The turtle sign is when the head kind of retracts back in after delivery of the head. What are some complications? So complications of shoulder dystocia, you can have brachial plexus palsy, fractures, hypoxia, and death. So now we have a male infant vaginally delivered. Delivery is complicated by shoulder dystocia. Post-delivery, the newborn has right arm that's adducted, internally rotated, and an extended elbow. Right arm has absent moro, but intact grasp reflex. So this would be ERBS, or upper plexus palsy, and this is usually self-limited. So what's the definition of oligohydramnios? So the deepest vertical pocket on ultrasound is going to be less than 2 centimeters, or the AFI is going to be less than 5 centimeters. And what are etiologies of oligohydramnios? So often it's idiopathic. The fetal etiologies could be there's ureteral obstruction, renal agenesis, autosomal recessive polycystic kidney disease. Maternal, you can have placental insufficiency in a late pregnancy, or PROM. And what are some complications of oligohydramnios? So this would be intrauterine growth restriction, or Potter sequence. And what's the etiology of Potter sequence? So you have the intrauterine compression from oligohydramnios, which decreases space for fetal development and fetal fluid ingestion. What's the clinical presentation of Potter sequence? So you get a lot of things, but craniofacial abnormalities, you get flattened nose, receding chin, low-set ears, prominent epicanthal and intraorbital folds. Skeletal deformities, you get hip dysplasia, congenital torticollis, and joint contractures and wrinkly skin. So the P in Potter stands for pulmonary hypoplasia, O for the oligohydramnios, T for twisted facies, T for twisted skin, E for extremity deformities, and R for renal agenesis, which is the classic form, or what causes the Potters. And what about polyhydramnios? How would you define that? So the AFI is greater than 24 centimeters, or the deepest vertical pocket is greater than or equal to 8 centimeters. And what's etiologies of polyhydramnios? So this is often also idiopathic, so you can get fetal anemia, impaired swallowing, just for any reason, so GI obstruction, compression, craniofacial deformities, any reason for increased urine production in the fetus, torch infections, and then mom can also have diabetes, and that can cause this. And what are some complications of polyhydramnios? PROM, but most mild cases resolve without treatment, and you can use amnio reduction or indomethacin if the polyhydramnios is severe or symptomatic. So a newborn is delivered to a G2P1 woman who has an O negative blood type. Within hours, the infant develops jaundice, lethargy, pallor, and they also are noted to have hepatosplenomegaly. Lab test shows anemia, elevated bilirubin levels, and a positive direct Coombs test. What are you concerned for here? So this would be hemolytic disease of the fetus and newborn. And what's the pathophys of this? So you get fetal hemolysis caused by maternal RBC antibodies due to Rh incompatibility. You can also get ABO and Cal incompatibility rarely. So in Rh incompatibility, D negative mothers form anti-D antibodies when a mother has a D positive baby. And so in the first pregnancy, the mother is exposed to the D positive red blood cells. And in the second pregnancy, the anti-D IgG from the mother goes to the fetus. And what kind of complications can that cause? That's kind of where you get that hemolytic anemia and then also hydrops, specifically hydrops fetalis. And how do you prevent this? Maternal screening for the D antigen and anti-D antibody. If D negative, you're going to want to give RhoGAM whenever there are risks of fetal bleeding, so whether so vaginal bleeding or trauma, and then at 28 weeks as well. So a 30-year-old G2P2 is 3 weeks postpartum, presents with fevers, chills, localized breast pain. Exam reveals erythema, warmth, tenderness in the upper outer quadrant of the right breast, no fluctuance. She reports difficulty breastfeeding and has on that affected side, but denies nipple trauma. What are we concerned for? So we're concerned for lactational mastitis. And what's the most common bug that causes lactational mastitis? Staph. Aureus, I should specify. And how do you treat this? You treat this with dicloxacillin or cephalexin. Mom can continue nursing during. So now we have a 28-year-old G1P1 woman postpartum day 4 with persistent fever despite antibiotic treatment for presumed endometritis. She has on exam a rope-like mass that is from the uterus to the right lateral abdomen. What are we concerned for here? So this would be septic pelvic thrombophlebitis, and what would next steps be? So we want to do imaging to confirm the diagnosis. We're going to want to give antibiotics, so Clinda and Gent plus anticoagulation. So 1 week postpartum, a patient has depressed mood, insomnia, and fatigue that started 3 days after delivery. What would this be? This is postpartum blues, which typically resolves within 2 weeks. Treatment is supportive. So the same patient comes back 2 weeks later, still having symptoms, now having poor concentration and guilt as well as other symptoms above that we talked about. So this would be postpartum depression now. So it meets the DSM criteria for depression, and treatment would be with CBT and SSRIs. So now a different patient with history of untreated bipolar disorder comes 5 days postpartum with concerns about their newborn. They've not been feeding the baby as they're concerned someone's trying to poison the baby. What are we concerned for here? Postpartum psychosis, and you can treat this with antipsychotics and ECT.